disease. So it's a zoonotic disease. Agent is a spirochete belonging to the genus Leptospira. We have ictrohemorrhagica type. The burden of the disease in India. Just remember, in Kerala, all the 14 districts are affected. And these are the other areas where you get the disease. So this is the epidemiological triad of the infection. Direct transmission through contact with an infected animal, indirect transmission through contact with contaminated urine, water, or soil. And the risk factors, this was earlier male gender, now everybody is at risk factor, all those who are going out. Behavioral and environmental drivers of risk are also there. High rainfall and flooding is an important part, poor sanitation, and tropical and subtropical climates. So high-risk groups include agricultural workers, animal handlers, vets, slaughterhouse workers, research workers, sewage workers, flood-affected areas, drivers, and construction workers. See, this is very important because now what we are seeing is even with the continuous rainfall of few hours, the roads are getting flooded. The roads are getting flooded, so there'll be some mixing from the drains and everything. So it's very important that there is a chances of more and more leptospirosis cases in the coming days. So it is very important that we recognize. See, by these two are together, dengue and lepto. Dengue, we don't have a specific treatment for it. It's only symptomatic management. We watch, wait and watch, look whether they're going to complication. In leptospirosis, we have a definite treatment. If it is started early, definitely it is going to prevent the complications and reduce the mortality. So it's very important that we start treatment at the earliest in case of leptospirosis. So the incubation period is 5 to 14 days with a range of 2 to 30 days. Again, here the case fatality is 0 to 15%. So the type, we can divide it as anectric leptospirosis, icteric leptospirosis, and severe leptospirosis. Anectric is a milder form of the disease. Patient will have fever, myalgia, do not have jaundice. So almost 90% of the patient have this type of illness. So again, the symptomatology, we have fever, myalgia. Same thing with dengue. So if we are confused, there's nothing, we can always start with doxycycline. That is what I'll be telling towards the end. What in monsoon, any fever coming with, any patient coming with fever, severe myalgia, even if with giving them a benefit, we can always start them on doxycycline. We can always prevent leptospirosis progression. Again, you can manage scrub typhus with doxycycline. So 90% of patients will have anectric leptospirosis. It's the 5 to 10% of patients who have icteric leptospirosis, which is the severe form of the disease characterized by jaundice, usually associated with involvement of other organs in the form of renal involvement, pancreatitis. And severe leptospirosis, there is hemorrhage, acute renal failure, acute respiratory failure, and ultimately multi-organ failure. So symptomatology, initially there is fever, myalgia, and conjunctival suffusion. This is the triad, what we say usually. Headache. Some patients come with nausea, vomiting, diarrhea, abdominal pain. Some earlier days, when we were doing our MBBS, it was like if the person comes with respiratory symptoms, it is not leptospirosis. But now it's not like that. Even patients coming with cough, chest pain, sometimes they have leptospirosis. Later on, they develop jaundice, oliguria, bleeding tendency, respiratory distress, cardiac failure, convulsions, and coma. So clinical findings, what you see is there is fever, muscle tenderness, especially there is calf and thigh tenderness. Okay, you just press, patient will jump with pain. Sometimes what happens is the patient will come as weakness of limbs, not able to walk for a neurology consultation, but mostly it is because of severe pain. They are having a pseudo paralysis like condition. Low backache, congestion of eyes. Later on, they may have subconjunctival hemorrhage, jaundice, hepatic, pulmonary, and renal involvement. Complications can occur even in the first week. There's bleeding tendency, thrombocytopenia, liver failure, acute kidney injury, acute respiratory distress, hypotension, myocarditis, pancreatitis, convulsions, and coma. So at this point, what I want to stress is, with leptospirosis, in the early stages itself, we have thrombocytopenia. Dengue, usually, if it is a primary infection, we see with the decrease in fever, there is subsiding of fever, there is decrease in platelet count. But dengue with secondary infection in the initial stages, you can have thrombocytopenia. So that is one thing, just keep in mind. So investigation. So first 3 days, usually we don't investigate for fever. Even if you see, what you usually see is neutrophilic leukocytosis. And this is another point which I want to stress. Urine routine, if you do, it's a simple test which is not invasive. They just have to give the sample. If you see pus cells or you see granular cast, most probably it will be leptospirosis. Okay, until unless your patient is having a chronic kidney disease, then maybe they can have granular cast and pus cells because of that. But otherwise, in a normal person who's coming with high grade fever, you do a urine routine and you see pus cells and granular cast, most probably it will be leptospirosis. So what happens is the moment you see pus cells, everybody what they do is cefixime or ciprofloxacin is written for urinary tract infection, even though they're not having any urinary symptoms. So that should not be done. Again, doxycycline is a medication which can be used even in urinary tract infection. It's a broad spectrum antibiotic. So even if you see pus cells, along with that, if you're seeing granular cast, most probably it will be leptospirosis. Start with doxycycline. Lepto-PCR can be done in the early stages. Usually we, last year infection we had sent, but none of it came as positive. After 3 days, there will be mild to moderate thrombocytopenia, increase in serum bilirubin with disproportionately low elevation of liver enzymes. Usually it will be less than 500, but you can see up to thousands also. There is increase in blood urea and serum creatinine. There is increase in creatine phosphokinase and increase in serum amylase. This is associated pancreatitis. After 5 days, even if it's set 5 days, you can always send it by 7 days. At the time of discharge, an IgM ELISA can be done for a confirmatory test. See, if you're suspecting leptospirosis, you do all the tests, you do an IgM lepto. If it is negative, you're not going to stop the treatment. Because there can be a lab error. If clinically you're thinking it is leptospirosis, your patient is having thrombocytopenia, urine patient is having granular cast and pus cells, whatever the antibody result, you have to continue with the treatment. So treatment, first 3 days may be treated as OP patient if vitals are stable. If the patient is available for follow-up, treatment is doxycycline 100 milligram BD for 7 days. If over 2 years, the doxy dose is 5 mg per kg per day, 12th hourly. Less than 2 years, amoxicillin 50 mg per kg per day or azithromycin. Toxic patients with red flag signs and organ dysfunction, they need parenteral antibiotics. So the drug of choice is crystalline penicillin 20 lakh units IVQ 6th hourly for 7 days. Or you can give ceftriaxone 1 to 2 gram BD for 7 days. Ciprofloxacin and macrolides are alternatives. Even though it is said, actually last year, I had a young patient, a 21-year-old boy, who came with fever of almost 1 week duration. Liver enzymes were high. 300, 400 counts were towards the lower side. Platelet count was actually normal for the patient. So we were thinking in terms of possibly 1 week fever, it could be enteric fever. And because it is enteric, ceftriaxone we gave, and we thought ceftriaxone has got a even leptospira coverage. But still, even after 48 hours, the fever persisted. So by the time 7th or 8th day it was, we had sent for IgM lepto, it came as positive. Then we stopped ceftriaxone, started the patient on CP. Patient was getting oral doxycycline also, but then also there was no improvement. We started the patient on crystalline penicillin, and after the second dose itself, the fever just came down. So I don't know. CP is, if the patient is not allergic, CP is the best drug. You start with that. For children, this is the dose. Crystalline penicillin 3 to 4 lakh per kg divided dose 6th hourly for 7 days. Or ceftriaxone. Or we can give injection doxycycline 200 milligram IV loading dose followed by 100 milligram BD for 7 days. Or azithromycin IV 500 milligram 5 days. Steroids in leptospirosis, severe leptospirosis with multi-organ failure. A pulse steroid with injection methylprednisolone 1 gram IV has got a very good prognosis. Last year, we had 2 patients who were with leptospirosis, myocarditis, AKI, hepatorenal dysfunction, and both of them survived. We had given methylpred for them. So it has got a good result. Now, these are the red flag signs. If the patient, there is no response to antibiotics in 8 hours, respiratory rate more than 24, urine output less than 20 ml per hour, BP less than 100 millimeter, tachycardia out of proportion to fever, flapping tremors, altered sensorium, hemorrhagic manifestations. So these are the red flag signs. Now, in case of, this is another thing which I want to stress, that is regarding the doxycycline prophylaxis. Whom to give, when to give, what to give. So there is a categorization. There is no contact with flood waters, muddy, polluted water, dead or sick animals, no risk, no need for doxycycline. a one-time contact with intact skin, with flood waters, muddy, polluted water, dead or sick animals, the risk is low. Doxycycline 200 milligram, that is 100 milligram 2 tubs stat once weekly for 2 consecutive weeks. That once weekly, 2 consecutive weeks you have to give for single contact. Continuing contact, you're giving doxycycline 200 milligram once a week as long as the exposure continues. Next is any contact with water, soil, or mud where there is wound, cut, or open lesions. In such cases, you're supposed to give doxycycline 100 milligram BD for 5 days, then ensure weekly prophylaxis as long as exposure continues. So sometimes what happens is in well, there was a rat is in Eli chattu kandu. But you can take it as a high risk contact. You can give 100 milligram BD for 5 days. And weekly prophylaxis only as long as exposure. So for them, only 5 days is enough. Special situations, pregnant and lactating mothers, azithromycin 500 milligram once a week. In children 2 to 12 years, doxycycline 4 mg per kg body weight once weekly. Children less than 2 years, azithromycin 10 mg per kg body weight once weekly. So all short febrile illness with severe myalgia with an epidemiological link should be managed as probable leptospirosis and start on doxycycline at the earliest. This is one point which I want to stress. And these are just few points on non-pharmacological general management of fever. All fevers, hydration is very important, rest is important, tepid sponging is important. We have to increase the body surface area being sponged, and it's not just forehead. And some danger signs. Any patient with fever, fever with rash, fever with seizure, fever with bleeding, fever with jaundice, fever with reduced quantity of urine, fever with breathing difficulty, fever with altered behavior, fever with giddiness, we have to refer. Take home message, you have to watch for warning signs, avoid NSAIDs. This is another extremely important point which I want to stress again and again, because all the fevers, short febrile illness, the dengue fever, lepto, this comes with severe myalgia, but you have to explain it to the patient. They'll be like, you just tell, if you take painkiller, you tell them, from here we give only passive. You go out and take painkiller, your kidney will go. Nobody is going to take the medication. So it's very important that you tell them regarding the problem. If they take NSAID, what is going to happen? Then hydration, balanced diet and rest is important. Adapt preventive activities as part of life. Prevention is always better than cure. And this is my last slide, which is my thank you slide also. I have just written the AWARE classification of antimicrobial agents, because there's different category of doctors who have joined this. So antimicrobial resistance